Thank you. Hi, everyone. Welcome to the Oxygen Therapy and Critical Care case-based series. Before we begin, just a few reminders. We will be using the chat function for question and answer. The button to access this is at the bottom of your screen, so please send all questions and comments you have through the chat today. If you have any technological issues, send us a message again through the chat and we would be pleased to assist. And this session is being recorded and your attendance is consent to being recorded, so thank you. So today we are on session 8. The topic is high flow nasal cannula and non-invasive ventilation. And with us we have Dr. Ananya from Cpap University College of Health Sciences and Dr. Yushek Abraham. We're pleased to have both of them. And with that, I'll pass it over to Dr. Ananya to get us started.
Thank you, Alana, for a nice introduction. Good afternoon, everyone. Welcome to our monthly eco session on oxygen therapy and critical care. So our today's topic, as Alana is saying, high flow nasal cannula and non-invasive ventilation. Today I have with me Dr. Isaac, who's an anesthesiologist and critical care specialist. Most of you know him. He's just a recent graduate with a very high score from our college at Addis Ababa University, and he has an intense interest in critical care, and he will be with us today as a panelist for this session. Saying so, I would like to thank Dr. Anna, who is editor-in-chief of Stanford Anesthesia Division of Global Health Equity, who's the owner of this program, and also Assist International and the Project ECO. They are making this teaching available for all of us, and we are grateful for having them. So I will ask Dr. Isaac maybe to share the screen, and I will go through the introductory part of today's session. Yeah, so as usual, how we go today is through a case scenario. This is about Mr. G, a 39-year-old male, presents with tachypnea and hypoxemia. So we have a disclaimer. So we are here to help providers make the best decision for patients. We remind the participants that discussion and content on the Learning Resource Center, a service to promote exchange of knowledge and experience of healthcare providers. Discussions are in no way intended to substitute for clinical judgments and independent decision-making of qualified healthcare professional. Administration of the Learning Resource Center make every attempt to provide up-to-date and accurate information. However, information changes rapidly, so individual healthcare providers are going to be responsible for adapting information to fit availability of resources and the standards of care in their own institution. So, yeah, so education is free.
Dr. Yushek, I think Dr. Ananya just dropped off. Do you want to step in until he's back? Okay.
Okay. Thank you. Good afternoon, everyone. So I will continue where Ananya left with our practice change objectives for today. The first one is on high flow oxygen therapy, which includes to understand the upper limit of low flow devices and differentiate between low flow and high flow oxygen therapy, and understand when to escalate to high flow oxygen therapy, and list some proposed benefits of high flow oxygen therapy and also their complication, and understand how to titrate high flow oxygen therapy and also down titrate high flow oxygen therapy. And when we get to the non-invasive positive pressure ventilation part, we will try to list some of the indications for NIV therapy and list some proposed benefits and also complications of non-invasive positive pressure ventilation. So I will start by reading our case for today. Mr. G, a 39 years old, presents with 5 days of worsening shortness of breath and dry cough. His breathing is harder when he gets up and walks around. So he has tried to stay in bed and rest. And he noticed that his fingers and toes are blue when his breathing is the worst. And past medical history includes obesity, BMI of 35, and type 2 diabetes with oral hypoglycemic agents, and past surgical histories, which includes appendectomy at age 20. He has no any history of allergies, and he works as a house painter, is divorced, one son, aged 10, and he does not smoke, drinks beer on the weekends. This is the case for today. We'll go through case updates as we go through our learning process. So I'll start with the high flow oxygen therapy. Before I go through this, there is some notice I want to give, because high flow oxygen therapy and NIV are considered to be an aerosol generating interventions. So we need to be careful. So we need to have PPE for both the patients and also ourselves, so that we can protect ourselves and also the others. So make sure you have your PPE before you proceed with high flow nasal oxygen therapy and also NIV. So I will start with our first question for today, which is, which low flow oxygen delivery device delivers the highest Fio2 from the choices, which includes the nasal cannula, the simple face mask, nasal catheter, mask with the reservoir bag, and Venturi masks are our choice. Let's see what you think, and write your answers in the chat box, and we will go through the answers later on. Okay, nasal cannula, Venturi. Okay, someone said E in the chat box, and poll we have Venturi mask is already leading by 67%. Okay, Atakliti said D, mask with reservoir bag. Okay. Okay. Macho said D, mask reservoir bag. Okay.
So far, I can see 14 of our participants participated in the poll.
Oh, yeah.
Yeah, so we need more people to participate.
So in the comment section, Stefano said D, mask reservoir bags. Rafael said Venturi mask. And Elizabeth said mask reservoir bag. Okay.
So on the poll, I can see 7% saying nasal cannula, no one says simple mask, around 14% nasal catheter, 21% mask with reservoir, and the large majority, around 57%, is saying Venturi mask, which is 8 of the participants, 8 of 14 who participated.
Yeah, most participants in the chat box, they said mask with reservoir bag. Okay, I think we can go through this. Okay, so I will reveal the answer now. So let's go through all the choices one by one, starting from the nasal prongs of the nasal cannula, which can be adapted for adults or any pediatric patients with flow delivery ranging from 0.5 up to 5 liters per minute, with Fio2 delivery ranging from 28% up to 40%. That's for the nasal prongs. We have the, although not mentioned in the choices, nasopharyngeal catheters, which can be used in the infants and child, with flow ranging from 0.5 up to 2 liters, with Fio2 delivery ranging from 45% to 60%. A simple face mask, which can also be used both in adults and child, with flow in liters delivery ranging from 6 up to 10 liters per minute, with Fio2 ranging from 44% up to 60%. And then we have this mask with reservoir bag, which can also be used both in adults and child, with flow delivery ranging from 10 up to 15 liters per minute, with Fio2 ranging from 60 up to 95%. So making this mask with the reservoir bag the one which can deliver the highest Fio2 from just choices we have. The other one is the Venturi mask, both adaptable in child, adults, with flow delivery ranging from 4 to 15, with Fio2 ranging from 24% up to 60%. What makes it Venturi mask different from the other one is that it has its own color-coded equipment which can adjust their own fixed flow and Fio2, which makes it different from the other oxygen delivery system. Then last we have this, the head box, the incubator or the tent, although not recommended by the WHO, since it has wastage of oxygen and hypercapnia is a risk, and also 2 to 3 liters per kg of flow is needed, so to avoid this rebreathing of carbon dioxide. This is all going to lead to a wastage of a high amount of oxygen. So depending on our choices, the highest effect can be delivered with mask with a reservoir bag.
Yeah, I think Dr. Isaac, it was a very nice detailed description of the different oxygen delivery devices. So many of our participants, I think, they chose Venturi mask because it's maybe now newly arriving in Ethiopia, and it's a new term, and they may think that it can administer higher fraction of inspired oxygen. but the reality is mask with a reservoir bag because it has a reservoir. So the next time patient breathes, the patient breathes from the reservoir volume, which is 100%, nearly 100% oxygen. So that's why the upper limit may get to 95, but the Venturi mask is in a way designed, to define the amount of Fio2 we are going to give to the patient. But because it doesn't have a reservoir, you cannot concentrate oxygen higher than 60% or so. But the only advantage could be you can know how much Fio2 we are giving based on a color-coded valve system. So this should be made clear for our participants. Yeah.
Yes. Thank you, Dr. Ananya. So next we have a case update. So Mr. G has the following vital sign: temperature 38 degrees Celsius, the heart rate is 99, and blood pressure, the non-invasive apparatus, systolic 107, diastolic 88, and respiratory rate of 28, with saturation 90% on face mask with reservoir bag on 15 liters per minute. So based on that, we will have a question. So can you list signs of respiratory distresses in adult patients? So you can either write it in the chat box. Okay, Mazmura said tachypnea. All right, thank you. Okay, Idarsal said use of accessory muscle, grunting, cyanosis, tachypnea, mentation change. Thank you very much, Idarsal. Matusala said chest retraction, abdominal breathing. Elizabeth said suprasternal and intercostal retraction. Okay, thank you. Mahalit said fast breathing and short breathing. You meant shallow breathing, maybe, I don't know.
Yeah, short of breath. The patients will
Short of breath, okay.
Breath.
Okay, short of breath, okay. Subcostal, intercostal retraction, tachypnea, nasal flaring again, and Mahader said restlessness, diaphoresis, intercostal, subcostal retraction, nice. And Atakti said tachypnea, use of accessory muscle, paradoxical respiratory, and desaturation, okay, thank you. And Sisai said respiratory rates greater than 30, accessory muscle use, mentation change. Okay, that's very good.
I think we had enough
of
those symptoms and signs.
Yes, most of our participants have said it all. I just want to clarify and also play with video. So I think you have said it all. Breathing rate is one sign. Increased breathing rate is a sign of person having trouble breathing. Color change, as we have seen in the patient or our case, he has color changes in the fingers, the lips. So that's one sign of respiratory distress, and the color may appear pale or gray on the skin and bluish color on the lips and the tongues and the fingernail. Grunting is also another sign. It's a physiological way of trying to keep air in the lungs so that they can stay open, just like a peep. And nose flaring, you've said it all, retraction, and also intercostal, subcostal retraction, sweating, wheezing, and body positions are also leaning forward, are also, it's also one sign of respiratory distress. I think I will play you a video, and if you have any additional points. Okay, I think you can see most of the things you have mentioned in the chat box are like you can observe in this patient. He had retractions, intercostal, subcostal. I couldn't comment on the others, but he has like abdominal breathing, looks pale. No, if you can see on the sides, maybe bluish. So most of the signs of the respiratory distress are included in this video. I think this is a nice one. If Dr. Ananya, you have any other points to add?
Yeah, maybe, you know, when there is a body position change, like when people are leaning forward, then it is, to me, that it's an imminent sign of collapse. So we shouldn't be waiting until the patient collapses. So respiratory support needs to be initiated ahead of time. Yeah.
Yes. So we have another question here, true or false. So a high flow nasal cannula is oxygen delivered through a standard nasal cannula at flow greater than 6 liters per minute. So anyone who agrees or disagree with this, let me know in the chat. So Seaside said true, Nasal true. Okay, true. Okay, false, we have true. Mazmura said false. Samacho said true. And Tesma Mariam said true. Idarsal said true. In the polls also 77% said true, 23% false. So let's have a few more answers and we can go through their explanation. Maybe the ones who said false, can you just briefly justify? So in the polls, still 74% true and 26% goes for false. As he said, it needs humidifier. Okay. And yes, attackly it needs humidifier, but can you more elaborate on the flow? Surafil, okay, it can it's false. He said false, and because it can deliver more than 60 liters per minute, not 6 liter. Okay, Idarsal said 4 to 6 liter without humidifier. Jenny said wasting and traumatizing. Okay. So the polling as stands true, 15% or 75% of our participants say true, and false, 5 people say that. Or okay, I think we will go through the answers now. So by definition, just a high flow, you might find different definition on different guidelines, but more than 10 liters is considered to be a high flow. But when we say a high flow nasal cannula oxygen therapy, there is an air oxygen blender, as you can see on the picture, and allowing for up to FiO2 delivery up to ranging from 0.1 up to 1 FiO2 and generate up to 60 liters per minute of flow. I think our participants have clearly said that. And the other things, what makes it peculiar is the gases, it heated and humidified. That's why the reasons why some people gave it the name heated humidified high flow nasal oxygen therapy. So through this activated, heated, humidified, and delivered via a single limb heated inspiratory circuit, and the patient breathes this adequately heated and humidified medical gas through nasal cannula with a large diameter. So this heating and humidifying process makes it tolerable for the patient to breathe with this amount of high flow, which can go as high as 60 liters per minute. So I will play a video for you now, which can clearly elaborate things you have tried to say now and I've tried to mention. So I will play the video. Sorry.
High flow therapy. High flow therapy is when oxygen is being delivered to the patient at a flow rate that meets or exceeds their inspiratory flow demand. What does that mean? Well, did you know that at rest, the average adult will inhale at a speed of 20 to 30 liters per minute? In other words, if someone was standing next to you right now with a radar gun pointing at your nose, capable of measuring how fast you're inhaling while you're relaxed, the speed at which you inhale would be at around 20 to 30 liters per minute. So high flow therapy should be capable of matching the inspiratory flow, or even exceeding it. If an oxygen device delivers less than the patient's inspiratory flow, then the delivery is called low flow. So because the average adult who is at rest inhales at a speed or flow of 20 to 30 liters per minute, a high flow device should be capable of delivering at least that much. Now, in order for this high flow of oxygen to be comfortable to the patient, the oxygen should be heated and humidified to maximize patient tolerance and comfort. And sometimes you'll see high flow therapy described as heated and humidified high flow oxygen therapy, or heated and humidified high flow nasal cannula, or to keep it short, it may be referred to as HHFNC or HFNC or even HFOT or HFT or some other variation of that. More recently, Vapotherm has chosen to refer to their heated high flow therapy as HVNI. They've even tried to describe HVNI as mask-free NIV, but don't get thrown off. On the FDA's website, it clearly identifies their device type as high-flow humidified oxygen delivery device. Now, like other high-flow devices, they deliver a high flow of oxygen, and it is heated and humidified to help meet patient comfort and tolerance. And some devices, like Vapotherm's Precision Flow, go up to 40 liters per minute. Others, like the F&P Airway 2, go up to 60 liters of flow, while still others can go even higher, because at the end of the day, we're just trying to meet the inspiratory flow of a patient, and when that patient is in respiratory distress, that inspiratory demand can be as high as 100 liters per minute. Yikes. So should high flow therapy be a replacement to other forms of therapy like non-invasive ventilation? The answer? Absolutely not. High flow oxygen delivers just that, a high flow of oxygen. But sometimes patients have issues with CO2 or ventilation, and not just issues with O2 or oxygenation. NIV is effective for both oxygenation and ventilation. This is why HFT and NIV are often used together on some patients in a complementary fashion. For example, some patients may be on high flow therapy but require more support. Clinicians sometimes escalate to NIV to prevent, if possible, intubation and invasive mechanical ventilation. And if a patient is on NIV and can tolerate short breaks, clinicians sometimes switch to high flow therapy to allow the patient to have that temporary break from NIV where they can eat, talk with their relatives, take an oral medication. You get the idea. In fact, in a Vapotherm-sponsored study, there were 104 patients who presented to the ER in respiratory distress, and they were initially placed on high-flow oxygen. Of those 104 patients, unfortunately, 27 of them failed, and of the 27, 4 were immediately intubated. But the other 23 patients were switched from the high-flow oxygen to NIV. And of the 23 patients who failed with high-flow oxygen and were switched to NIV, 20 of them improved and did not need further escalation to intubation. In fact, in another study, patients at high risk of post-extubation failure were placed in one of two categories. The first category was high-flow therapy only, and the other group allowed for both NIV and high-flow therapy. Now, the patients that went on both NIV and HFT had a significantly lower rate of reintubation versus the group that went on HFT only. So don't get confused. HFT is definitely not mask-free NIV. But it is a great tool to treat patients with oxygenation issues who are in respiratory distress. So, just a quick final summary on high flow therapy. High flow oxygen therapy usually delivers oxygen at a flow rate equal to or higher than the patient's actual inspiratory flow rate. It should be heated and humidified for patient tolerance, and depending on the flow rate and the seal around the nose and mouth, high flow oxygen may create a Cpap effect, although we don't know exactly how much. It also may wash out some CO2 that is in the upper airway, which is often referred to as CO2 dead space washout. But again, we don't know exactly how much. So that's your quick introduction to high flow therapy.
Okay. So I think everyone now gets the idea with about this high flow oxygen therapy, the reason for it to be heated and also humidified. So I think this video answers this question very well. So the thing about high flow nasal cannula, it's all about replacing the demands of the patient's mouth. So most of our patients are going to require a very high amount of flow rates, which cannot be satisfied with the low flow devices we have, like the simple face mask or the nasal cannula. So to make things comfortable, the devices has a humidifier and also heated air. So this makes it a bit comfortable for the patient to breathe and also eat, chat with their families, and also attending physicians and so on. So these are some of the benefits of the high flow oxygen therapy. So we have a case update. So despite receiving oxygen by mask with the reservoir bag, Mr. G continues to have a fast rate of breathing tachypnea. So his respiratory rate is now 36 breaths per minute, and saturation has fallen to 88%. And the bedside provider decided to place him on high flow oxygen therapy. So we have some practice change objectives. So we will list some of the benefits and the complications of high flow oxygen therapy and understand how to up titrate and down titrate high flow oxygen therapy. First off, let's start with the high flow oxygen therapy in the chat box. Some of the benefits were also mentioned in the video. You can have, maybe you have read something somewhere else, or you've experienced something. I would love to hear it in the chat. So Elizabeth said it will prevent intubation complication, and Idarsal said can give 100% oxygen. Okay, anatomical dead space flushed, provide warm humidified gas. Okay, very nice, Dr. Idarsal. I think avoids early invasive ventilation. Okay, since I said patient comfort, decreased level of distress, improve oxygenation and ventilation. PEEP effect aids on ventilation and also oxygenation, and also can improve cardiogenic pulmonary edema. Both can be used, ventilation and oxygenation, and better clearance of fluid secretions due to humidified air, better tolerated and more comfortable, easier to communicate during therapy, easy to eat and drink, easy, less mouth dryness, reduced air. I think that's excellent. Faculty said PEEP ranging 1 per 10 liter per minute, high flow oxygen comfortably. That's good. As Subalo said, provide some Cpap and decrease dead space, carbon dioxide washouts. That's excellent too. Okay. And reduce nasopharyngeal airway resistance, decrease dead space, avoid risk of ventilation, invasive ventilation, and like aspiration and hospital-acquired infection. Can give high Fio2, can wash common. So I think some participants were saying it avoids invasive ventilation. I don't think you have seen it in the video too. If there is a clear indication for invasive ventilation, there should not be a delay or hesitation to intubate the patients. Usually, it can might lead to delay in intubation, so we don't want that. So maybe that we shouldn't mention it as a benefit, because it cannot be a substitute for mechanical ventilation. And other answers, economical, is that it avoids invasive, again, okay, can be used at emergency department, pre and post extubation, that's excellent. Hayat said better tolerance, apneic oxygenation, that's excellent too. And less dead space ventilation. Haptamu said faster patient recovery, and can be used for obstructive sleep apnea. I think these are some good comments we are getting now. And I think one participant also said it avoids complication of intubation like aspiration and so on, but I don't think so, because we have patients also who can be at risk of aspiration when they are on high flow nasal cannula. So you need to individualize it from patients to patients. So patients who have clearly risk for aspiration, you don't have to go for. So we have to protect the airways with intubation. And daily versus PEEP, I think most of you have said it very nicely. I will reveal the answer. So the benefits, so these are some of the clinical and physiologic benefits we get from a high flow nasal cannula. So the first one, as most of you have mentioned it, is enhanced patient comfort, because there is a small pliable nasal prongs which makes it comfortable for our patients and facilitates removal of airway secretions, because there is no obstruction with the face mask, unlike the NIVs. So there is also benefit of avoidance of airway desiccation and epithelial injury due to this heated and humidified gases, so decreased work of breathing and enhanced patient's comfort. One mechanism for that is heating and humidification. The other one, as most of you have mentioned it, the washout of this nasopharyngeal dead spaces, which leads to improved ventilation and oxygen delivery. And also, most of you have also mentioned it, the PEEP effects, which if there is any auto PEEP, can unload it, and also decrease the work of breathing, and also enhanced oxygenation are other benefits. And last but not least, there is this high flow rate, which can reliably deliver an Fio2, unlike our simple face masks or nasal cannulas, in which their Fio2 is mostly dependent on the flow rate. But we have this high flow nasal cannula where we can separately adjust the Fio2 and the flow rate. So there is also improved breathing pattern, like increased tidal volume and decreased respiratory rate. I think most of you have mentioned it very nicely in the chat box. Also, thank you very much. So I will proceed with the next. Dr. Ananya.
Yes, Dr. Isaac, was very nice. Our participants almost mentioned all the benefits. So there was issues, mentioned, like avoiding intubation. So I think our participants are understanding this in the context that if we initiate early high flow nasal oxygen therapy, maybe a need for invasive ventilation can be prevented. But once it's too late and the patient starts to collapse, then there's no way to put the patient on any form of ventilation other than this invasive ventilation. So in our setup, we lack most of the time high flow nasal therapy or even non-invasive ventilation. So we put patients on face mask with a reservoir, and they stay there for a very long period of time. Even there is no any escalation. So as early as possible, if we escalate our therapy to high flow nasal catheter therapy, then that's what maybe our participants are thinking in the long run. Maybe in the course of the illness, early intervention may improve patient's condition rather than just jumping to invasive ventilation. But as Dr. Isa clearly said, if someone has a clear indication for ventilatory management, then they have to put on a ventilatory management. And as you can see on the video, high flow therapy, oxygen therapy gives oxygen, but not ventilation, meaning it won't be delivering, tidal volume, but it can improve, a work of breathing. So we need to differentiate between the two. Yeah. And maybe, the other thing is, aspiration. So definitely maybe high flow nasal cannula may create, even increase the risk of aspiration. As one of the side effects, we'll see it later, will be, distending of the stomach, and this might predispose the patient to regurgitate, and this can lead to, the risk of aspiration. So these are points. Yeah, thank you.
Okay, thank you, Dr. Ananya. So I will proceed with our next question. So can you list the possible complications of the high flow oxygen therapy? So you have very nicely mentioned most of the benefits of the high flow oxygen therapy. So I need your active participation again. Okay. So Transfer Mariam said dry nose, dry throat, and Tensai said pneumothorax, epistaxis. Okay. Irsal said epistaxis, gastric distension. Excellent. Okay. Okay. Okay, generally, there are very few risks associated with high flow oxygen therapy. Occasionally, the nasal prong may become blocked if there is a lot of mucus. Okay, thank you. Stefano said oxygen toxicity. High flow can be uncomfortable early. Hot inspired air can be less tolerable early, but not much complication. Okay. Jenny said barotrauma, mucosal damage, aspiration, pneumothorax. Excellent. Okay. And you said absorption atelectasis. And someone said dry ped nasal trauma, gastric distension. Okay. Tissue injuries, Omar. And Naptamu said eye irritation, nasal and oral dryness, gastric distension. Okay.
Yeah, I think we had enough participants.
Okay. So, okay. The complications, as you have mostly said, there's not much complications, but there are some complication and there are some grave and rare complications like abdominal distension, aspiration, and rarely barotrauma with pneumothorax can occur in patients who are on high flow nasal cannula. But comparing it with the NIVs and mechanical ventilation, the risk of this barotrauma is lower with high flow nasal cannula. As you can see from this image, we have this patient was on high flow nasal cannula with subcutaneous emphysema. We have a very small upper lung pneumothorax. So you have mentioned it very well in barotrauma, also a very rare complication of high flow nasal cannula. It can happen in patients like this one, very bilateral opacity with most. So applying a high flow therapy in these patients with a very low compliance of the lung might lead to the barotrauma, but comparing it with NIVs and mechanical ventilation, which pushes the gas with a positive pressure, they have a much higher complications of pneumothorax in these patients. So this is one example. So we have another question. So I want you to mention some 3 parameters that we set on high flow oxygen therapy device. And I want you to list them on the chat box. So 3 parameters we set on a high flow oxygen therapy device. Okay, Darsal said gas source, humidifier, and nasal interface. Miriam said humidifier, and Sisai said flow rate, humidifier temperature. One more. And this will be very perfect answer. And FiO2, yes. So these are the three parameters we usually set on a high flow oxygen therapy. Okay, Samacho said high flow rate, humidifier, and heated. Hidersal said pressure relief valve has to be adjusted. FiO2 said, nice, yeah. Now you completed your answer. And nasal interface, Omar says. Okay, Mohammed said FiO2, oxygen pressure and temperature. Okay. Okay.
I think for the sake of time, we can proceed to the
yeah. Okay, I think this video will clearly demonstrate this.
In the previous video, we talked a little bit about what high flow therapy is. In this video, we'll quickly highlight the clinical application of high flow oxygen therapy. We already discussed that high flow therapy is not a replacement for non-invasive ventilation because it is not capable of providing the same level of ventilatory support like NIV. In high flow therapy, for example, there is no inspiratory pressure setting, no peak or Cpap setting, no backup respiratory rate setting, no inspiratory time setting, no patient ventilatory alarms. You also cannot monitor the tidal volume, the IE ratio, and there are no loops or waveforms. You get the idea. NIV, on the other hand, can provide all of these. In fact, the only two main controls on high flow therapy are FiO2 and flow. Let's look at FiO2 first. This is typically adjusted to maintain adequate oxygenation. The FiO2 can be set from a level of 21% to a level of 100%. Usually, patients in acute respiratory distress who are on high flow may initially require a high level of FiO2 to maintain an appropriate saturation. Next is the flow setting. The flow is usually set to try to meet or exceed the patient's inspiratory flow demand. This is challenging because it's difficult to determine what the patient's inspiratory flow is. We learned in the previous video that at rest, when the patient isn't in respiratory distress, the typical inspiratory flow of an adult is around 20 to 30 liters per minute. But for patients in distress, their flow demand will likely be higher. So clinicians often titrate the flow according to the patient's respiratory rate. In other words, the faster the patient is breathing, the more flow they'll probably need. So if you're using the Vapotherm's precision flow device, the highest flow that you can set is 40 liters per minute. On other devices, like the Airway 2, they can go as high as 60 liters per minute, and still others can go higher. So these two settings, the flow and FiO2, are the two settings available to the clinician to treat the patient in respiratory distress. If the respiratory rate or the CO2 on the arterial blood gas cannot be corrected or stabilized despite a relatively high flow rate setting, you may need to escalate to non-invasive ventilation or even intubation, depending on the severity of the hypercapnia. Likewise, if the pulse ox or the PaO2 on the arterial blood gas cannot be corrected and stabilized despite a relatively high FiO2 setting, then be prepared to escalate to non-invasive ventilation or even intubation, depending on the severity of the respiratory failure and the diagnosis of the patient. But whatever you do, do not delay escalation if the patient does not improve with high flow oxygen. Okay, now remember, because there are no patient alarms and data monitoring is not available on high flow oxygen devices, regular patient monitoring is critical. There is one more control in high flow therapy, and that's the temperature setting. To ensure that the high flow of oxygen is tolerable, heat and humidification should be provided. The exact appropriate temperature setting is debatable, and there currently exists no temperature standard. Some suggest to start at 37 degrees Celsius, others suggest start lower, but the key point in temperature setting is to adjust the temperature based on patient comfort and tolerance. Which patients should high flow therapy be placed on? It's still a bit unclear, but we tend to see good outcomes in patients with what we call De novo hypoxemic respiratory failure. De novo hypoxemic respiratory failure is defined as significant hypoxemia but in the absence of chronic lung disease such as COPD. We also do not include the kind of respiratory failure that occurs in the immediate postoperative or post-extubation period. Remember, high flow therapy can deliver a high FiO2 at a high flow rate, so we anticipate it to be beneficial for hypoxemic patients. However, if a patient presents with acute hypercapnic respiratory failure, which is exhibited by an abnormally high CO2 and a corresponding abnormally low pH, then clinicians may want to consider an alternative form of intervention, such as NIV. Well, what about you? How have you seen high flow therapy used? Leave your comments below. I would love to read some of your responses.
Okay, thank you. So I think that's a very clear explanation on the settings we have on high flow oxygen therapy. So we have another question. So list indications of high flow oxygen therapy in the chat box. Okay, Omar said hypoxemia. Edersal says hypoxic respiratory failure, pre-intubation, oxygenation, yes. Okay. Mario said acute heart failure, ARDS, acute respiratory distress, asthma, bronchiectasis, chest trauma, such as fractured ribs and exacerbation of COPD, lung cancer, pneumonia, pulmonary edema, and CSI said hypoxemia, anticipated difficult airway, post-extubation, cardiogenic pulmonary edema, and Mohammed said atelectasis, hypoxemic respiratory failure, ARDS, Nasal patients who refused intubation. Okay, and Tensai said post-extubation support. I think okay. Let's go over the answers together. And okay, I will say DNA patient with respiratory patient. Okay, thank you all. Okay, I think we have a figure here which clearly sets some of the indications for high flow nasal cannula. I think most of you have mentioned it in the chat box. The first one with a strong recommendation is the hypoxemic respiratory failure, and like we have seen also in the video we've played previously, and also following extubation, but not in the patients who are in respiratory risk for respiratory failure at post-extubation. And also in post-operative and for high flow nasal cannula in high risk and obese patients following a cardiac or thoracic surgery. This is a conditional recommendation with a moderate certainty, and we can also use it as a pre-intubation period as a pre-oxygenation, which is also mentioned in the comments, but there is no recommendation currently. It makes it special in high flow nasal cannula and pre-intubation. But I think most of you have said the benefits in the chat box, so thank you all. So we have two more questions. So the first one, which one of the following is incorrect regarding the parameters set by provider when delivering high flow oxygen therapy? So it's a choice. You can go ahead and try it. There is a poll also. So choice A, provider can use respiratory rate to estimate the initial flow setting needed on the high flow oxygen therapy. Choice B, provider can directly measure the flow at which the patient is breathing and match their respiratory flow demand on the high flow oxygen therapy device. The average respiratory flow of the adult renal trace is 20 to 30 liters. And D, the flow rate set on high flow therapy should attempt to meet or exceed the patient's respiratory flow demand. And E, respiratory flow demand increases during respiratory distress. So on the poll, we have choice A, 20%. Two people also said C, and also D, 1%, and E, 1%. So which one is the incorrect choice? Okay. Okay, in the chat box, someone said, Sisai said B. Okay, and so most people chose B, C, and D on the poll. And okay, faculty also said B. And someone also said A and B. Okay, that's interesting. And B, okay. Okay. Okay, someone said A and B. Okay, another choice B, the middle. Samacho said also B. And on the poll, 48% said B. Okay, I think let's reveal the answer. I think most of you have said B, both on the chat box and on the poll. Most of you answered B. So, okay, thank you all.
Almost 50% is B.
Yeah, choice B. Yeah, that's the correct answer, the incorrect answer actually. So, as we have seen it clearly on the video, there is no currently, you cannot directly measure the flow the patient's breathing. You just estimate it by looking at the respiratory rate. You can estimate the initial flow setting starting on that. So we don't have a direct measure for the flow. The other choices are correct. So next question. In which of the following scenarios would providers need to escalate from high flow oxygen therapy to either non-invasive forced pressure ventilation or intubation with mechanical ventilation? So we have A to B. You can either choose in the polls or the chat box. Choice A, respiratory rate does not correct or stabilize despite receiving high flow rates on the high flow oxygen therapy. The patient's partial pressure of carbon dioxide remains elevated or worsens on a BJ analysis despite receiving high flow rates on the high flow oxygen therapy device. Saturation doesn't correct or stabilize despite receiving high saturation on high flow oxygen therapy device. The PaO2 does not correct or stabilize despite receiving high Fio2 on high flow oxygen therapy device. And E all. So on the poll, we have 7 people say 11 now. All of the above. Okay. And in the chats, all. Okay, the general faculty said all, Macho said all, Peter Star, the Peter, and Jenny, Nathaniel, all. And in the poll, so one person say D. Okay. Think Yeah, Tamu said all, so not Nail. Okay. Okay. Okay, almost half our audience have participated. Thank you. And most of them have chose the answer E, all of the above, which I quite agree with them. So, which is this also clearly mentioned in the video we have seen previously. So most of the choices, all of the choices are an indication to escalate to high flow, to NIV or intubation. So one last question, what is the ROX index? How can it help providers? So let's see your answers on the chat box. What is the ROX index? ROX index. Okay, there's also the calculations to know failure rate. Okay. Maybe can you mention some of the components, Idarsa? Okay, I said saturation, Fio2, and again divided by respiratory. Excellent. And okay, good predictor of high flow nasal cannula failure and saturation. Okay, predicting intubation probability. Okay, components include saturation, respiratory. Okay, thank you, Nathaniel. Okay. And yeah, good predictor of high flow oxygen therapy success. I think, thank you all. I think most of you mentioned it very nicely. Yes, it's a ratio. It's one way of predicting patients intubation who are on high flow nasal cannula. Its components include saturation, as you have most of you have mentioned, and a Fio2, and also the respiratory rate. And based on that, you can have your own results, which ranges from like 2.8, the lowest one, and the assessment of the ROX index, usually it's assessed at 2, 6, and 12 hours, and usually values ranging in the intermediate range, 3.85 up to 4.87. We need to assess them 2 hours later, but our values greater than 4.87 are a good sign that the patient can tolerate this high flow oxygen therapy. So this is a one way, very good and nice way of following our patients who are on high flow nasal cannula, because there is no other monitors which are, or any sensors which are attached to the high flow oxygen therapy, which can tell us the patient's probability of failing or succeeding. So based on our clinical observation, like we get from monitors separate from the high flow nasal cannula, we can estimate the success of the patient's therapy, oxygen therapy. So this is one good way of estimating high flow nasal cannula. Dr. Ananya, if you have anything to add.
Yeah, so generally what we need to look Of course, this index is very important, but in other terms, it's to mean that if the saturation of the patient is not good, the respiratory rate is higher while the patient is on high flow nasal cannula. And also the Fio2 we are using is high, like 100%. Then this is a patient who's likely to fail from intubation. So looking into these three variables, we can assess whether we are in a good track or this is a patient who's failing. So we need to take into consideration these variables.
Okay, thank you. So we have a case update. So Mr. G remains on high flow oxygen therapy with the following setting: temperature 37 degrees Celsius, FiO2 100%, and flow of 60 liters per minute. And after 2 days of initial improvement, his saturation is 90%, but he is more tachypneic with a respiratory rate of 35 breaths per minute. He appears fatigued. His arterial blood gas analysis reversed the following: pH is 7.27, PaCO2 is 58 millimeter of mercury, PaO2 is 60 millimeter of mercury, and the bedside team decides to try non-invasive positive pressure ventilation. So we will go through now the non-invasive positive pressure ventilation. So as again, remember to put your PPEs on you and on your patients and on you, because it's one of the aerosol generating intervention. So our practical objectives includes to list some of the indications and proposed benefits and possible complications of NIV. So our first questions, which includes, can you differentiate between, what's the difference between non-invasive ventilation, non-invasive positive pressure ventilation, Cpap, and BiPAP? Can you just briefly describe them in the chat box? Okay, the Jenny said NIV includes those listed. Okay. Smart answer. Is there any difference you can think of? Okay, Idarsal said BiPAP is the two-level, both inspiration and expiration positive airway pressures, whereas Cpap is only single pressure. Okay, excellent.
Yeah, I think this one is a tough one. Maybe
Yeah.
I'm not able to write it down. So let's go ahead with the explanation.
So, yeah, so a bit tricky, and so the difference between this NIV. So let's start with the Cpap. I think one of our participants answered it well. Cpap has a constant pressure which is applied throughout the respiratory cycle via face mask or other interface to split open the upper airway and increase the lung volume, increase the intrathoracic pressure. But the Cpap provides no respiratory inspiratory muscle unloading, so tidal ventilation remain completely dependent on the respiratory muscles. But it's just a term which But NIV and NIPPV, BiPAP are all the same, but the principle is that there are two levels of pressure which is applied during the respiratory cycle. A pressure during the inspiratory phase that's greater than the pressure applied during the exhalation. And this effectively, mechanical ventilation can unload the respiratory muscles and provide complete respiratory support. So this is, I think, one of our participants also has mentioned it very clearly. BiPAP is just a brand name which is developed by Philips. So I think you have very nicely answered it. So a non-invasive ventilatory supports, it can be used in acute or chronic respiratory failure and chronic respiratory issues such as stable COPD, neuromuscular disorders, chest wall disease, obstructive sleep apnea, obesity, hypoventilation syndrome. Although they will not be discussed during these sessions, these are some of the benefits we have with the non-invasive ventilation.
Yeah, so, Dr. Isaac, if they want to know more about these issues, they can join the Learning Resource Center and read through the article. There is a website on open critical care. So they can know through the different terminologies. One of our, participants interestingly raised the issue of non-invasive ventilation could also include negative pressure ventilation, because it doesn't say, non-invasive positive pressure ventilation. It is something to be considered, but, what we literally use it as the same as, positive pressure ventilation. It's just an issue of naming. Okay, so Cpap could be a bit different from the rest, but the rest are all interchangeable. So interchangeably being used, but negative pressure ventilation has to be also considered, is what our participants saying, and we can accept that as well.
Okay, thank you. So we have a video on this non-invasive ventilation.
Hello, my name is Nick, and in this video we're going to look at Cpap, continuous positive airway pressure, and non-invasive ventilation, also known as BiPAP, biphasic positive airway pressure. Cpap is a way of keeping the pressure positive in a spontaneously breathing patient's lungs. This positive pressure helps keep the smaller airways and alveoli open, which allows for additional gas exchange to take place by recruiting areas of a lung that might otherwise have collapsed down. A tight mask is applied to the patient's face to create a seal. Air and oxygen now flow through a circuit attached to the mask at high flow. The patient exhales through a valve which closes when the desired pressure is achieved. This pressure created by the valve is known as PEEP, positive end expiratory pressure. It's this that leaves the pressure in the patient's lungs at the end of expiration. There are several tight-fitting masks that can be used: oral masks, naso masks, full face masks, and Cpap hoods. Cpap has been shown to be particularly useful in acute cardiogenic pulmonary edema and congestive heart failure, where, in simple terms, the positive pressure created helps push the fluid out of the lungs and into the circulation and prevents further fluid coming back into the lungs. It could also be used for pneumonia, sleep apnea, and atelectasis. So what is non-invasive ventilation? Sometimes just keeping the alveoli open isn't enough, especially if the patient develops type 2 respiratory failure and starts to retain carbon dioxide. Think of non-invasive ventilation as Cpap with added zing. Non-invasive ventilation is used to increase the size of each breath taken by the patient. It gives an assisted push behind the breath which increases its size and thus reduces carbon dioxide levels by blowing off CO2. It seems to be most useful in conditions such as exacerbation of COPD and post-extubation on ITU. Some success has been reported with asthma patients as well as certain other respiratory conditions where there may be reluctance to sedate, intubate and ventilate a patient due to existing risk factors. So how does non-invasive ventilation work? As with Cpap, a tight-fitting mask is fitted to the patient's face, but this time the patient breathes through a mechanical ventilator. On the ventilator, two pressures are set. Firstly, the positive end expiratory pressure, PEEP, similar to that used in Cpap. As before, this pressure helps preventing the alveoli from collapsing. Secondly, the pressure that creates the push. This is the inspiratory pressure, which increases the size of each breath or tidal volume. The bigger the pressure, the bigger the push, the bigger the tidal volume. So let's assume that we set the PEEP at 10 centimetres of water. The pressure in the patient's lungs will not drop below this level. It's now the baseline pressure, if you like. Now assume we set the inspiratory pressure at 15 centimetres of water. Note that the inspiratory pressure is added on top of the PEEP. As the patient takes the breath, it causes the ventilator to initiate. It now increases the pressure until the inspiratory pressure is achieved. Once the inspiratory pressure has been reached, the expiratory valve opens, the pressure begins to fall, and the patient exhales passively until the pressure drops back to the PEEP level, where the valve closes to maintain the pressure. The inspiratory pressure can be adjusted until the desired tidal volume has been achieved, usually about 6 to 8 mils per kilogram. In addition to the pressures in both non-invasive ventilation and Cpap, oxygen levels must be set. For various reasons, this is frequently referred to as the Fio2, or fraction of inspired oxygen. The Fio2 is expressed as a fraction, so that 100% oxygen is expressed as an Fio2 of 1 and 21% oxygen is expressed as an Fio2 of 0.21. So, to summarise, Cpap uses high flow and positive pressure at the end of expiration to keep the alveoli open and improves oxygenation. Non-invasive ventilation gives a push behind each breath to increase the size of the tidal volume, which in turn lowers carbon dioxide levels. So that's it, a very basic overview of Cpap and non-invasive ventilation in under 5 minutes.
Okay. Yeah, thank you. I think this video has tried clearly to mention some of the applications of Cpap and non-invasive ventilation. So we have a question now. There are two conditions leading to acute respiratory failure in adult patients that have very strong evidence of benefits from non-invasive positive pressure. Can you mention those two conditions in the chat box? Okay, since I said COPD, also intensive COPD, COPD exacerbation. Nasal said asthma, COPD. Okay. Macho said COPD, also. OSA, COPD, Nathaniel, COPD, and asthma, COPD, and OSA. Okay. So, most of the things you are mentioning are some benefits we get from a non-invasive positive pressure ventilation, but so there are two conditions which have been studied very well and have shown. Okay, someone said also CHF. So clear benefits from this non-invasive positive pressure ventilation, evidence-based. So ARDS from Fuzon. Okay. Nothing. Okay. That's an excellent participation. Thank you all again. So I will reveal the answer. So these are the two conditions: the acute exacerbation of COPD, as you have most of you mentioned it, and also acute cardiogenic pulmonary edema. And also you mentioned this also. So thank you very much. So the evidence behind this is from the European Respiratory. European Journal of Respiratory Journal and also the American Thoracic Society. They have both thoroughly studied the application of this Cpap and NIVs in patients with COPD and acute cardiogenic pulmonary edema. And they have clearly found that bilevel is more preferred in acute exacerbation of COPD and have shown that reduced mortality, reduced rates of intubation, and reduced lengths of hospital stay has been described in patients who are on NIV for acute exacerbation of COPD. And the other one is acute pulmonary cardiogenic edema, though Cpap is preferred in this case, and reduced intubation, reduced shortness of breath, and also reduced mortality has been shown compared with the control group. So these are the findings I got from the finding we got from the European Respiratory Journal and also the American Thoracic Society. So thank you all for your participation. I think you've all mentioned it. So can you mention some of list contraindications to non-invasive positive ventilation, the chat box? So contraindications to non-invasive positive non-invasive intermittent positive. So either outside unconscious patients, okay, the upper GI bleeding, frequent vomiting, uncooperative patient, mentation change, excellent, thank you so much. And since I said patient's refusal, depressed mentation, unable to protect airway, thank you again. Unconscious, uncooperative patient, excessive secretion, thank you. Yeah, and uncooperative patient, patients that cannot protect the airway, altered mentation, hemodynamic instability, excessive secretions. These are very excellent. Hemodynamic instability, fascial lesion, okay, different answer, but good choice. And patient high risk of aspiration, comatose patient, and patient with respiratory arrest, uncooperative. That's and inability to protect the airway, and respiratory arrest, burn involving the face, facial, esophageal, gastric surgery, apnea, reduced consciousness, air. I think these are very excellent answer. Thank you all again. So I will reveal the answer now. So these are the most the contraindication to non-invasive positive pressure ventilation. So absolute contraindication includes an urgent need for intubation, mechanical ventilation, like in cardiac arrest, respiratory arrest, which you have mentioned it very rightly. Okay, thank you again. And the relative contraindications include facial or neurologic surgery, trauma or deformity, upper GI bleeding or active MSS, and encephalopathy, need for prolonged mechanical ventilation, inability to cooperate, protect airway, and clear secretion. And last but not least, obstructed airways are some of the contraindications to non-invasive positive pressure ventilation. I think you have all mentioned it all. Thank you again. So I have a case update for you. So Mr. G is placed on a non-invasive positive pressure ventilation for 1 hour with pressure support ventilation of 15, PPO 5, and FiO2 is set to 100%, and his respiratory rate is 35 breaths per minute. And he appears fatigued, and he slumped over in the bed and arouses only with shaking. So what's the appropriate next step in the Mr. G's care? You can mention some interventions we can have for this case update. Okay, intubate him. Okay, thank you. Habtamu, intubation. Tensei, invasive ventilation. And Sual also said needs intubation. Consider invasive management, intubation. Okay, intubation, yes. Invasive ventilation, okay. Yeah, controlled invasive ventilation, yes, okay. Yeah, I think, yeah, thank you all. Yes, I think patients have already, as most listed, contraindication for to continue this positive, non-invasive positive ventilation. So our finals are asked to be invasive ventilation, since the patient can no longer protect his airway. He might be at risk for respiration, and also he might also fatigue. He has a very fast rate, 35 breaths per minute, and mentation has also changed. So these are some of the contraindication to continue the non-invasive ventilation and continue with the invasive ventilation. So thank you all. I think you can get the reference for this discussion in the Telegram page. Thank you, Dr. Ananya. If there is anything you want to add.
Thank you, Dr. Isaac. It was a very nice moderation of this session. I really want to thank you. Thank you all participants. Now we come at the end of our session. I'm sure you have got some information regarding high flow oxygen therapy and non-invasive ventilation, the difference between them. So you'll get more information on our Learning Resource Center, which will be shared through email as well as Telegram. And now overall in world as well as in our country, the COVID-19 infection rate is escalating, increasing, and we have to be careful and be strict with our PPE, as this variant Omicron is also highly transmissible. So when you are using high flow nasal cannula or non-invasive ventilation, please be careful and use personal protective equipment. And I would like to say also Merry Christmas and Happy New Year for those of you who are joining us from outside of Ethiopia. Our new year is on the month of September actually, but our Christmas is also coming, which will be on January 7. So thank you all and see you next time. Maybe Alana, you can close the session.
Thank you. As Dr. Ananya said, the presentation materials is available on the Learning Resource Center. So if you would like to review everything that was discussed today, please follow that link. It's been shared in the chat. Otherwise, we hope to see you in January for our 9th session on pediatrics. And until then, happy holidays and happy New Year.
Bye, everyone.